There we go. So right. So thank you so much for that presentation, Stefan. I'd like to say I'm first of all a clinician. I came into this profession as a clinician. I loved working as a chiropractor. I did so for 10 years full time. And 2012, I embarked on a PhD after a few years of engaging in practice-based research, where me as a clinician took part in a series of projects where I collected data and was part of a small part of designing the projects and also analyzing the data. And then since 2012, I've had the opportunity, I should say, and privilege, because I don't see it as Stefan does. It's an absolute privilege to have the chance to work with research since 2012. And I've spent 2 days still in clinic trying to keep a foot, well, first of all, a financial security in life, because research is very insecure. So having a clinic to fall back to if funds don't come in has been tremendous and allowed me to focus on research and not becoming a university administrator, which happens to a lot of people when you want to have a secure research position. So my view of research is from the clinician's point of view. I want to make, create work that is relevant to clinicians and that clinicians can use, because otherwise there is no point in my mind. So I've had the privilege to work with this, part of what I've done, most of what I've done, but I've done lots of other things as well. But this has been where my heart has been since I started, and it's been with this large project called the Nordic Research Program. And I'm going to do a short synopsis of that today, trying to push it into a recap so that we can frame the information that then comes, which is the maintain instrument, which is the practical application of this. How do we put it into practice? How do we use this information? There's so much to say, and just like Stefan said, if you guide me, I'm really happy to go into things that you find more or less interesting in this conversation. As a researcher, I love to talk method and statistics and data, and I know from my own experience of being only a clinician and from being with clinicians that is not often the case for clinicians. So help me along. If it gets boring, let me know, and I'll try to speed up and get to the juicy things. So let's see if I can move my screen ahead. Here we go. Right. So the Nordic Maintenance Care Program. Why did we start with this? Well, of course, it's an interesting topic. It's an important topic, I would even say, because it's something that's been part of the chiropractic professions really from the beginning. We had the first paper published about chiropractic by a chiropractor in the 70s. And already in that very first publication, maintenance care was mentioned. And it's come back in different publications and different work that's been done. But it wasn't really until the 2000s that we started doing work on trying to understand this concept as a whole. So it's an important topic because it also addresses some of those key diseases that we are challenged with in society today. How do we manage individuals with recurrent pain? How do we help them in the best way? So not only is it important for our profession, but it's important for society as a whole. It's definitely a politically charged subject. Really, before our research program, there was really two fields. One field that said, maintenance care is what we do. That's the core, that's the heart of the profession. We prevent disease. That's what chiropractors do. And then the other group saying, well, there is no evidence. That is just bullshit. It is just a money-making scheme. You should not do it. So it's been, and it still is to some degree, but less so since the work that we've done. It's also a really ambitious idea. Some of the people that designed this or started this program are the brightest minds that we have in our profession. They had a very big idea when they started this program. They wanted to build something from the ground up, so that in the end we could actually look at what we do in practice. And you'll see as I go through the publications here quickly how brilliantly this program has been thought out. Right, so let's move on. Well, you could say it all started 2008 with a literature review done by Charlotte and Lise Hestbeck from Denmark. Charlotte is Swedish, a professor in Denmark, and she's worked in France. And Lise is a professor now in Denmark. And what they set out to do was to understand what is the state of the literature? What do we know about maintenance care? And this was 2008. And they concluded there was no evidence-based definition. There were no indications of the nature or of its use. It was clear that chiropractors believed it was useful, and there was very little data on how common it was, how many used it and to what degree. And was it efficacious? Was it cost effective? Did it actually work? Did it help patients? Well, we didn't know at that point. So that was the starting stone. So instead of booing these people and saying, oh, you're pointing the finger at things we don't know, you should tell people what we do know so that we get reimbursed. Instead, they shined the light on a very important topic and said, look, we don't know anything about this. We need to spend some time and effort understanding this. And that's what happened. So about this time is when I got involved in research. So in some of these preliminary projects I was part of as a clinician collecting data. And that is something I'd really like to push. Stefan mentioned this early, that engaging in research is so important in so many ways. It's important to read research. It's important to do research. And doing research can be done in different ways. Being a data collecting clinician is an incredibly important task, because without all those clinicians that helped us collect this data, we would have none of the information that we have today. So, I mean, a big applause to all the clinicians since 2008 in this particular research program that has helped us collect data. They are the real heroes of this project. So 3 publications have been published on case management. We have see if we can get it up there. 1 publication on frequency of care. We have 4 publications on indications for care. We have a clinical trial, which is what I'll speak the most about, where we published a protocol and then the primary effect evaluation. And from that, after that, there was an updated systematic review that summarizes all the information up to here, which is brilliant if you're interested in knowing about this, but feel that reading all those papers that I just listed is too much. Read this one. It summarizes it perfectly. But since 2019, we've then moved on, and we've done some secondary analysis of the clinical trial, done a qualitative study where we've try to investigate patients' experiences of maintenance care. And we've now developed a clinical instrument, the Maintain instrument, to use to put this information into practice. So I'm going to try to summarize these, or the key messages from these papers, so that you are up to date with what we've done and what we are doing. Please let me know if there's anything in here that you want me to dive into, like I said, or any questions or anything that I am unclear about. So let's dive into what maintenance care is. Right. So first of all, prevalence. How common is maintenance care? Well, when we asked chiropractors, as in a survey, having them just off their head estimate how many patients, what is the proportion of your clinician or of your patients that are maintenance care visits, and then we get about 22 on average. When we ask chiropractors to go through their typical day in clinic to look in their medical records and count, we end up somewhere between 28 and 35%. And if we were to actually go into the clinics and count for each and every one of those visits, we end up somewhere between 26 and 41%. So you could say about a third of all visits to chiropractors are maintenance care visits. That's quite a lot. So why do chiropractors recommend maintenance care? Well, 95% say it's about minimizing relapse or deterioration of a chronic condition. 90% says it's about optimizing health. 88% it's about preventing illness, and 86% it's about managing chronic diseases, primary musculoskeletal. And why do patients choose maintenance care? So those were the ideas for chiropractors, as in why they choose it. Why do patients choose maintenance care? Well, they say often that it's about preventing recurrent pain, it's about keeping optimal function, it's about staying pain-free. So they have a very pragmatic relationship to maintenance care. It's about pain and function. So what do we do in maintenance care? What does it contain, the visits? Well, 97% of visits is SMT. 96% contains some form of exercise prescription. 93% is nutritional advice. 84% is lifestyle advice. I'm going to go back there, so I was a bit quick. Now, these are the estimates that chiropractors say that they do in their maintenance care visits. This is what we think we do with our maintenance care visits. Sadly, the truth is different. What actually happens when we ask patients or view the actual, when they come out of the clinician's office and then ask them what happened in there. And then 92% said, well, we discussed the health problem. In 8%, the health problem wasn't even discussed. In 88%, some sort of passive treatment was given. 66% received an examination, 51% some kind of manual muscular treatment, and 20% ergonomic lifestyle advice, and 17% received discussion of other health problems or had a discussion of other health problems, and only 10% received exercise advice. Now, this is, as you can see in the bottom, is from 2012, and a lot has happened in the, I think, in the chiropractic field, but also in the field of exercise science. So I would say if we were to do this today, it would likely be a higher number. But it's sad to see that only 10% here received exercise advice, given that that is the best available evidence we have today for prevention of musculoskeletal pain. Right, so if you were to go into the room and time the actual visit and say, you know, how many minutes of the visit did you spend on different components? So we can see a gray and a darker gray and a lighter gray bar here. And the darker gray is the maintenance care patients and the lighter gray is the non-maintenance care patients. So what we can see, it's rather similar. In fact, it's almost identical besides advice, which is slightly lower on the maintenance care side. So for non-maintenance care patients, they receive slightly more advice, but otherwise the content of what we do or the time we spend on the different aspects seem to be very similar. So how often do we see patients in a maintenance care plan? Well, it ranges somewhere between 2 weeks and 3 months. 2 months is usually the norm, and then we have outliers, some that treat patients really frequently, weekly, or even 2 or 3 times a week, and some people that never use it. So there's a wide range, but there is a core group of individuals, the majority, that has a very similar way of approaching maintenance care, where we see visits being booked somewhere between 1 and 3 months usually. Right. So what about the thought process? Do we just choose everyone, or is there some kind of reasoning to this madness? Well, there is. It seems that uncomplicated patients are treated for a short period of time. Difficult cases, they're referred out. And recurrent cases are recommended maintenance care. So it's not mind-blowing. That would, for me as a clinician, this would be a very natural way of looking at this. But it seems anyway that across the Scandinavian countries, this is how you view the majority of cases when you select patients for maintenance care. Right. So now we're getting into to the really nitty-gritty stuff, the interesting bit. So I'm going to go a little bit deeper into the data that we have on effectiveness, because this trial was the it was the apex of all the research that was done. The idea was to understand the way clinicians worked and then to put that to test in a randomized clinical trial. And from that trial is most of the data that we have on effectiveness and subgroups and all the stuff we'll do. So this is a very important trial that you need to be aware of. So I'll go in slightly more depth here. And if there's some aspects of this that you'd like to know more about, let me know if I go too quickly. So it was a randomized controlled trial where we followed patients for 12 months. We had 2 treatment arms, one that received maintenance care, which was treatments, pre-planned treatments scheduled 1 to 3 month intervals. The other group had symptom-guided treatment, which meant the patient would call in as soon as they had pain. They got the recurrence of pain, they would call back, they would come in and see their doctor, they would have a few treatments, and then they'll go back to being carefree. The maintenance care group would have a similar situation. If they had a relapse during their maintenance care period, they would come back quicker and have a more intense period if they needed, but they would then be put back on this 1 to 3 month interval with the discretion of the chiropractor. What was interesting here was we had a selection process that was unique for this trial. We had clinicians treat patients in an initial treatment period that was variable. And so they treated them, and then at the 4th visit, we screened patients to see who were the responders to manual care. Because we know from our research before that patients that do not respond to manual care tend to not become maintenance care patients. That's an obvious one for a clinician. You wouldn't keep treating someone who doesn't respond. But in science, that is typically not what is done. Typically, you'd have a group of people, you treat them all, and then you'd say something about it. But what we did here was we tried to find those individuals that were responders to our particular type of care. And as far as we know, the only way of doing that is trial and error. We don't have a very good prediction rule of saying you are going to be well at the 4th visit when you see them at the 1st visit. There are some criteria that point you into a good or bad prognosis, but the best way of doing it is treating them, see what happens, and at the 4th visit, if they report a definite improvement, then we know that their prognosis is better at 3 months, 6 months, 12 months later down the line. So they were at the 4th visit, they were good responders. The clinician then treated them up to the point where they would normally say either bye-bye, come back when you have another issue, or let's put you on maintenance care. And that's when the patients were enrolled into the trial. So it was super complex. So we had to screen so many patients to get them through this whole process, to get all these clinicians to. So we lost a lot of people in the recruitment process, which is a shame. So what did we measure? Well, our primary outcome was number of days with activity limiting pain or bothersome pain. So they would receive an SMS weekly where they would respond. Last week I had 0 to 7 days with pain. And then initially we would have an assistant. They would get a reminder if they didn't respond, and if they didn't respond to the second reminder, we would have an assistant call them up and said, "Hey, you got an SMS. Why didn't you respond?" So most patients that got into the trial, they were on board, which meant that we ended up with an extremely good response rate, which you'd see in a bit. We also collected secondary outcomes in the beginning and at the end, where we looked at self-rated health, activity limitation, psychological profile, etc. There was a bunch of questionnaires for them to fill in the beginning and at the end. So 35 clinicians helped us recruit patients across Sweden. We screened 2,033 patients. Out of those, 328 were eligible to be entered into the trial. So we had 162 in the control and 166 in maintenance care. In the end, we had 7 dropouts and 2 were excluded because they got pregnant during the trial, which meant we had 319 individuals that we analyzed in the end, which is a rather large randomized control trial. And we sent out 16,692 SMS with a 98.9% response rate, which is exceptionally good. So we have this extremely rich data set of all these 319 patients over 52 weeks. And that's one of the absolute major strengths of this trial. The data here is super robust. So what did we find? So when we counted all those days together with the pain in the total of those 12 months, the maintenance care group had 13 fewer days with activity limiting low back pain. And they had two more treatments. It was a little bit better and a little bit more expensive. So we concluded, well, at an additional number of treatment, maintenance care is effective. Now, this is not a groundbreaking result. It's an interesting result, surely. It shows that maintenance care is effective. It shows also that it comes with a small increase in cost, not a lot. So it's still a very positive result, but it's not something that changes people's lives. So already from the outset, all those brilliant minds that designed this trial, they had an idea. They had an idea that there might be different patients that respond differently to maintenance care. So already from the outset, there was a plan to do a number of different secondary analysis to look at subgroups of patients within this cohort. So the main analysis that we wanted to do was to see if psychological factors affected the outcome of patients. So patients filled in a questionnaire called the West Haven Yale Multidimensional Pain Inventory. And it's a rather old questionnaire that was developed in the 80s, and it's been tested across cultures, across languages. It's been tested on a number of different pain conditions, ranging from cancer pain to TMJ, neck pain, low back pain, and have shown to be robust, reliable instrument. So although it's old, it does have some absolute gold in it in terms of understanding a broad psychological profile. There are some incredible downsides to this instrument. One, it doesn't capture those modern ideas about pain, such as catastrophizing, fear of movement, etc. It captures the patient's experience of pain from a cognitive behavioral perspective. And it takes a long time to fill out. There's a lot of questions, and you need statistical software to process this information to come up with whether these are risk groups or not. So you can say that once they've done this and you've processed the data, you get three different risk groups: the adaptive copers, the interpersonally distressed, and the dysfunctional. The adaptive copers is the group you want to be in if you were to have long-standing pain. The adaptive copers is the group that has good coping skills, that are able to deal well with their pain. They're usually not affected emotionally. Life works despite their pain, and they're usually quite active. We have the interpersonal distress group, who has an issue with behaviors where they have a difficulty in owning their problem and blames the exterior world of why they have pain. It's because of my workplace, or my spouse doesn't help me with that, or it's my friends that do this to me, and they have an issue of owning their problem. They have a worse prognosis than the AC group. And then we have the dysfunctional subgroup, which is the worst of them. They have usually good support because they are in fact very ill. They have high pain severity, they have high distress, are highly emotionally affected. They are usually quite passive and unable to deal well with their pain. This group has the highest risk of long-term sick leave, and often results in the highest costs for society in terms of sick leave and production loss. This is the group that we need as a society to target if we want to beat the low back epidemic. And like I said, it's based on the cognitive behavioral conceptualization of pain. Right, so when we split these groups up, so what you see here is a chart where we have all these three groups together. We have the adaptive coper group, the interpersonally distressed group, and dysfunctional. And what we see here is the difference between the groups. So it's maintenance care minus control. So if the control group has more pain, we would have a negative result here. If the maintenance care group has more pain, we have a positive result. So for the first one, the adaptive coper group, when we analyzed them as their own little cohort, we found that the adaptive coper group had 10 more days with pain if they received maintenance care. So they got worse. This was statistically significant. You can see that little dot is the mean value, and then the little whiskers are the 95% confidence interval. So it was a statistically significant negative difference for the maintenance care in this group. The interpersonally distressed group, well, it was equally effective or not effective, effective or not effective. We have the same result. They had equal number of days with pain, but the dysfunctional subgroup had 30 days less with pain, 1 entire month. And that is a very interesting result, especially when we contrast that with the adaptive coper group that actually gets worse. So what about cost of visits? So same analysis, same logical processing here. The adaptive coper, the one that got worse, remember, 10 days more, they also had 4 more visits. They got more treatments if they got maintenance care. They got more pain. So that's not a very good idea. And then we have the interpersonally distressed group. They were slightly more expensive in terms of visits. So they had a few more visits, and you remember they were equally effective. But what about the dysfunctional group? Well, the mean value is slightly above 0, but as you can see, the confidence interval includes 0, which means it's not a statistically significant difference. We can't really say that they were more expensive, but we can say that they were very much more effective in this group. So that is an incredible result. Here we have a group where not only is the intervention better, but it doesn't result in a higher cost. And that is unheard of, not unheard of, but it's very uncommon when we talk health economics, because often they develop a new pill, and that pill is slightly more expensive compared to the old pill, but it's a little bit better. So then there's a question, how much are we willing to pay for this added extra effect? And that's usually the discussion in health economics. Very seldomly we have a dominant intervention like this, where we can say it's better and it's cheaper or equally expensive. Right. So let's see if we can understand this even better. We've chosen to call this the clinical mechanism, and it's not really, because we're not really looking at the mechanism, but rather trying to see how does it actually affect patients. So 30 days, how do they get affected by it? What are the positive outcomes? So how does it work? Does it prevent new episodes? Does it increase pain-free episodes in between events? Does it depend on the frequency of treatment? Meaning, is more treatment better than less treatment? And is the timing of the treatment important? When do they get the relapse? Is it associated with when the visits happen? Or is maintenance care important to have a strategy where you see the patients before they peak in pain? Is that the whole point? Is that the skill of maintenance care, to understand the past trajectory of the patient and to foresee their next event? That's what we wanted to find out. So the first analysis we did was to look at the first event. So you can see here on the graph, this is just a graph to explain this. It's not an actual graph. So it's the time to the first new peak. So they might have a little bit pain, but the first new event. So there was not really, the maintenance care group had a little bit longer period, but it was not statistically significant. So what about if we counted all the pain-free periods in between the relapses? Well, if we do that, then we could see that the maintenance care group, among the dysfunctional patients, which was where we saw the effect, had 10 more pain-free weeks. So not did they in total have 30 days less with pain, but when you look at the number of pain-free weeks, as in between periods, they had almost 2.5 months more pain-free periods. And that is an extremely relevant finding. But also, and I find this really interesting, when we look at the pain trajectory around the visits, so this is a really complex graph. It summarizes all maintenance care visits and all the new visits in each new episode for the control group to look at what is the pain development of the trajectory. And as you can see, it's really rounded because we've used regression models to fit this. So in actual sense, it wouldn't be a round, it would be look more peak and be less regular. But this is as I mean. So for the control group, we can see from 3 weeks before to 2 weeks before, 1 week before, and then at the week of the visit, pain starts to increase. They see their chiropractor the week of the visit, and then pain goes down. This is what we would expect, right? They get a new episode, call their clinician up, get treatment, get better. That's what we want to see, right? But for the maintenance care group, it's much more flat. There's a slight bend in the curve here, but really there is no real peak or relapse, which means that we're catching people early. We're seeing them before they get that peak of pain. And probably some of the effect of those 30 days is us making the peak lower, making them less acute. So we're giving them less days with pain, longer pain-free periods, and probably less acute relapses as the pain comes back. Tremendous results. Really important for patients. So to summarize it, it does not prevent new episodes. It's not like we put patients on maintenance care and they never have pain again. They still get pain. But among individuals who receive maintenance care, we increase the pain-free periods and we seem to stabilize the event. And the effectiveness seemed to depend on timing, as in what I mentioned before, the skill of foreseeing their trajectory rather than a high frequency of care. So I think, and that rings well with me as a clinician, when I see where I've been successful with maintenance care in some of my patients, is when I've been able to foresee that and help them through those over time by managing those recurrences. Right, everyone with me? No questions, nothing? No? Good, good. So let's move on to patient experience. Now, this is also an extremely important paper that has just not been getting enough attention, I think. It's one of the few papers that we've done that's looked at patients' experiences overall of chiropractic care. And it's the only paper that I've looked at the patients' experiences from maintenance care. So what we did then is we used so-called semi-structured interviews, which means you have a manuscript with some questions that you want to, or areas that you want to address with some questions, but you're not limited to those. Those are to open up the conversation, to allow a structure in the conversation, but the patient is allowed to elaborate on whatever they want relating to your conversation. So we recruited 24 patients that had gone through the maintenance care procedure in our RCT. They were part of those receiving all those benefits that we talked about, that we just looked at. We had a so-called purposeful sampling. So we chose patients from different MPI subgroups, not only the dysfunctional, but from the adaptive corpus, the interpersonally distressed, and the dysfunctional. We chose patients from different age groups and with different sex, so that we can get a wide variety of experiences from those individuals who receive maintenance care. And then we use something called the theory of planned behavior as a theoretical framework to understand motivation and their behavior. I'm not going to address that, but if you think this is interesting, we write a whole lot about that in the paper, and we've even developed a maintenance care model about what drives maintenance care behavior based on the theory of planned behavior. I'm really proud of that, and it's really interesting. It's got no attention at all, which is okay. Most research don't. So what we found was there were two overarching dimensions that came out of this work. One was when patients described maintenance care as though it was of high value care. And one that was when they described it as low value care, something they felt was overpriced and not really valuable. So let's dive into that. So what did they talk about when they talked about high value? There were three categories here. They said it was about improving quality of life. It was about being structured, accessible, and appreciated, that they felt they appreciated it. And that it was patient-centered. So we're going to look at all these three because they had subcategories, and then go into a quote from each of these, and then we'll do the same for the low value. Again, there's so much more information on this in the paper that allows you to just with color understand patients' perspectives, undergoing chiropractic care in general, but maintenance care in particular. So when they talked about care that was improving quality of life, that was part of this high value perspective, they talked about being free of pain, about moving, performing better. And they said things like staying pain-free, staying well over time, improved physical abilities, healthier behaviors. When they say it was about making them feel great, it was about life enjoyment, positive emotions, improved self-confidence. They didn't want to be off work. It was about reducing sick leave. It was about being more productive at work. All these things that we don't capture in a randomized clinical trial when we ask about number of days with pain. So this really puts color onto those results where we can understand what it is that they actually experience as positive things, which is something that we're gonna come back to when we talk about the maintenance care instrument. Because it's not about putting a number on a person, it's about deepening a conversation about their abilities. Right, so the next one, so here's a quote from that category. Well, apart from the physical aspect, not to have pain, and how shall I put it, being more confident that my back and body can handle things I need to do, maintenance care has also helped my mental state. There was even one that described it as us being physical psychologists. Brilliant. So she continues, I don't know, is it he or she, to know that I can carry, play, and have fun with my children, be able to participate in physical activities without having to be left off on the sideline, wondering whether I can do it, has been invigorating mentally. Fascinating. Right. Next one, being structured, accessible, appreciating. They talked about it fitting into life, being readily available, being time efficient, effective. There was a small effort, no hassle. Those that had some sort of societal or employee reimbursement lifted that as a really positive aspect about how it made it fit into their life easier. They described it as a form of care or scaffolding for regularity and appreciation. That regular visit offered a continuity, motivation, and a feeling of reassurance. And many of them described it as an important piece of the puzzle that complemented other health actions. So a quote from that group was, when the pain came back, I knew I had an appointment booked, which meant I got help fast. I thought this was reassuring and felt sort of comforting. There was a period where I felt worse and wasn't as active with my training. During that time, it was very comforting to know that I had my appointment booked in advance. Now, we think this is one of the major drivers behind the effectiveness of maintenance care, that we're creating this scaffolding or security or structure that allows them to push behaviors and change behaviors to a degree that they might not be willing to if they didn't have that support of that pre-planned visit. They talked about patient-centered care. I love this. They talked about the competent clinician providing for a great doctor-patient rapport. They described the clinicians as professional, caring, with a personal relationship, and that provided guidance and information and education. But quote here, I would say that the clinician acted professionally and with care, which meant I felt trust and confidence in her ability as well as for the chiropractic profession in a way that I hadn't before. Right, so let's move on to the negative aspects of this when they perceived it as being of low value. And so three categories again came up. Does the benefit of maintenance care outweigh the cost? I mean, is it cost effective for me personally? Is it accessible? Some individuals had long distances to travel or had very few clinicians in their area. Is maintenance care being delivered congruent with a patient-centered perspective? So they actually lifted the other side of the coin when they met clinicians who they felt weren't patient-centered, and that was a real trigger of low value. So the first one, does the benefit of maintenance care outweigh the cost? Well, some said it's a considerable personal investment because most of these patients, or all of them to some degree, paid for their visits themselves. It was, time consuming. They had to get in the car and travel and get to the visit and go home, and it was a quite chunk of money that went out. Is it worth it? Some of them felt, it's a questionable benefit. I don't really feel that I'm getting the value here, and it seems like it's a really small part or one aspect of a much wider need of their health condition. So a quote here, if it comes up here. To set aside time to simply get away from work and everyday life is a barrier. Add to that the cost. It's fairly expensive for a short treatment session. One might be there for roughly 10 minutes for a largely amount of money. Right. So we've heard that one. I've heard that one. Is maintenance care accessible? Right. So it was about limited accessibility. It perceived as unavailable with logistical challenges to have it fit into their lives. And some of them also pointed out that they felt it was separate from mainstream healthcare. How can I trust this when it's not accepted by the whole? That there was an inherent social cultural belief about not being part of the system, and there was an impressive lack of knowledge with regards to maintenance care. Some of these patients who underwent maintenance care for an entire year actually didn't understand that they actually did. Right. So a quote here. Well, it can be difficult to find available treatment times if the chiropractor is popular. I perceived this as a challenge to find treatment time that suited my work schedule. Right. And then we have the patient-centered perspective again. And this is, here they talked about, there was an inadequate patient-doctor relationship, that there was an intimacy that didn't feel right, that there was a personal space that wasn't tolerated or respected, that the communication wasn't there, that there wasn't really a trust and rapport, and there was this sensation of retention. This is interesting. Now, consider this. They're in a study. They know there's a protocol to adhere to, yet some of these patients still felt that the chiropractor wanted them to come back when they felt they didn't need to or should. There were unpleasant feelings and experiences associated with care, undesired reactions, as in being sore or fear of being cracked or having things done to them. So here's a quote. If you have visited the chiropractor maybe 8-9 times, and then you feel, no, things are good, at that point, they sort of wanted me to keep coming, even though I felt done and didn't want to. I felt I could manage on my own. This was a little negative. So which group do you think this person was part of? Well, this was a classic AC individual, obviously. Right, so let's leave that behind us. I think there's so much to say about that paper, and I would love to spend an hour just talking about that. But read it. It's also a qualitative papers. They're much easier to read. There's no statistics involved. There's just words and quotes and things. So it's really nice to relate to as a clinician, to really understand the patient perspective in a way that you seldomly get to. Right, so all of this up until now was just to get you introduced so that you can understand this, the clinical instrument, which is the next part of this. How are we doing for time? Terribly.
Andreas?
Yeah.
No, it's beautiful. Can I, just before we go into the tool,
yes.
just field a couple of the questions that have come through, and one you've already answered, I think, if I'm not mistaken, Caroline. Caroline's asking, why do you think maintenance care didn't work very well, in the perceived sense of it, for the adaptive copers or the interpersonally distressed individuals? What is your personal view as to why that might be?
Yeah. So I think with regards to the adaptive copers, I don't know. These are my thoughts. I've discussed this with my research colleagues, but I don't have evidence for this, but this is what I think.
Mm-hmm.
I think these are individuals that are active. They have good coping strategies. They manage well. And the fact that we bring them back to remind them that they have pain is negative for their pain experience. They come in and are asked about things like, how's your back? How you been? What about this? They might get treatment, yet they don't feel like that last quote. They don't really feel the need for it or understand the need for it. So that it becomes rather than a positive experience, it's about something that reminds them about a negative health state, which allows them to put more focus on something that they actually don't need focus on. That's my.
Would you also agree that perhaps there's a sentiment of, so on the one hand, unnecessarily in their perception being reminded of a negative, but also potentially the intrusion of any experience with a cost associated, whether it be time or money, into their dependence or independence, sorry. Do these people tend to navigate the world in a fairly independent fashion?
Yes.
Compared to others, perhaps?
Yes. Probably, yes. Probably. I mean, this is not a personality trait. We think these categories can shift. You can go from a dysfunctional to an adaptive coper. It's not a trait that you were born with. It's about how you relate to this pain at this current state. No one's ever used the MPI instrument as an outcome measure, but it would be a really interesting to study to see, are we able to change profile? Can we address these dysfunction individuals and then see if we can change them into AC individuals? So I don't about money causing pain, as in I don't know. I think it's more about focus and reminding them about a condition that they're managing really well, and that that time could be spent exercising or doing other things that might even be more beneficial to them. Now, you got to keep in mind, we don't know the mechanism. As chiropractors, we like to think it's about biomechanics. Could be that we're helping with nociception and movement patterns, etc. It could also be entirely psychological. That there
seems to be a high correlation between that concept of dependence, independence, control, and locus of control, and then of course the interplay of locus of control and that sense of mapped out. I can push the boat out in the garden today because I've got an appointment on Tuesday. That kind of anticipated framework that you referenced earlier, that all reeks of concepts of locus of control to me. And just to segue into that, just to clarify, particularly with Caroline, so she also asked, was there any correlation between whether the patient viewed maintenance care as higher value and whether they were in the dysfunctional group versus the ACNID groups? I think you already answered that question with a yes, but please expand further if you have.
Well, then you misunderstood me because because those 24 individuals were too few to say anything about the group averages, is to say anything about whether they perceived it as high or low value. So we don't know. It would be a super interesting study to look at, but we don't know. I'd like to go back to one of the other questions that I didn't answer. What about the ID group? Why were they in the middle? Well, in the ID group, there's quite a spectrum. So you have individuals that resembles the AC, and then you have individuals that resemble the DIS, but they end up in the ID category for the behavioral reasons and for not being as extreme in the dysfunctional group. So it could very well be that the ID group, you have responders and non-responders. So if you were to cut them apart and say, we're the ones that were AC-like, they don't respond, whereas the ones that were dysfunctional, they might respond. And that we kind of solve that with the maintain instrument.
And just before, that's my personal question to you, Andreas. Would you say that perhaps there is that shift between the different groups, that actually the clinician themselves can, through their communication style, other factors within the clinic itself, that they could potentially conversationally and through their actions and the experience of the patient move a patient from one group to another. Going back to your point about you're not born in that group, you can move and transition. Is that perhaps where that the patient communication, the patient education, the salesmanship, the personal and interpersonal relationship between doctor and patient becomes highly relevant in moving people into a group that is going to benefit from these interactions?
I think absolutely, and the words we use, the content of what we do, and how we frame maintenance care. I mean, you could scare them with X-rays. You could tell them they have these untreatable or dangerous issues in their spine that they need to see me for, or they'll develop cancer. You can say lots of negative things that would lock them into the dysfunctional profile, or you could be that support that allows them to challenge their pain beliefs, push them forward, really congruent with like the mainstay pain science paradigm, where instead of locking them into a passive treatment schedule, we are a support network to push them further and help support them in that movement. So I think probably maintenance care can be beneficial and detrimental to those dysfunctional individuals, and that's been some of the criticism, particularly from physios, when we published these subgroup papers about about this individual. They've said, this is a vulnerable group. Are you going to lock them into treatment dependence, passive treatment dependence? I don't really see maintenance care as that. I see it as a safe framework to help them push out of passive dependence into the active role, the AC role. And so that would be the next step. As in, how do we?
That's where the tool then really comes in, isn't it? In terms of identifying who might benefit and with whom we should be having that conversation with authority and backed with evidence. So is this where then the clinical instrument itself becomes the valuable point for that? Great, thank you.
And you went into something there just before that. I was really happy, thought that you were going to answer that question, as in, don't clinicians do this automatically? As in, we talk to our patients, we have a case history, and then in just meeting with them, we can say, you're dysfunctional and you're an adaptive coper. Yeah, so I had that idea, and we tested that. We did a trial where we looked at that, where we're writing this paper up now, and it will be published hopefully sometime during this year, where we asked patients, we even made it a little bit easier for them. And so we created a structured case history. So we said, we want you to ask questions about these things. We want you to consider these topics, and we want you to evaluate that when you talk to them in your conversation, but you're free to ask anything, as into, are they high and low, etc. So they would be guided through an algorithm almost that would lead them to say, this is an ACID dysfunctional individual. So we had workshops, we trained them in this, etc., etc. So we thought, if they can do this, then there's a potential of them being in clinic just by talking to them that might work. But if they can't do this, then they surely can't do it just by talking to them without a structure in the clinical setting. And we found that they were pretty terrible. It was pretty bad. They were pretty good at like saying, you're not a dysfunctional. They were pretty good at saying you're an AC or an ID. But when it came to saying dysfunctional, it was almost better flipping a coin. So even though we created this, trained them in thinking about them, the cognitive behavioral model, trying to put them into these boxes, ask the questions that were relevant, that was really taking the MPI instrument and creating a clinical conversation around the MPI instrument for, say, 10 to 15 minutes. Even doing that did not help them, made them able to classify them into the right psychological subgroup. So it seems we need something to measure these things more better with.
Can we implement that tool? I'm assuming that's where you're going next, is the implementation of the tool.
Yeah, so that was not the tool. That was to say, can we do without the tool? That was what we wanted to find out. maybe we don't need the tool. Maybe we clinicians are smart enough to do this on their own just by talking to their patients. And we concluded that no, that is probably not the case. It's probably more time efficient to use this clinical tool, and it's certainly more effective in terms of finding the right individuals. Right. Shall I go on? So the clinical instrument. So we called it the maintain instrument because it's obviously about maintenance care. And it's about maintaining a condition, as in having some kind of maintenance protocol for some kind of condition. 10 questions. They're from the MPI instruments. So each of these questions have been validated. They've been translated into different languages. So I think we have a German version. So we could put together a maintain instrument in German. I think we have it in Spanish. We definitely have it in English and Swedish. There are some nuances in terms of how the questions come out, which you'll see in a bit, where it becomes a little funny for English speakers when they use this instrument, whereas in Sweden, we don't have that issue. These 10 questions come down to 5 dimensions: pain severity, interference, life control, support, and effective distress. These are some 5 of the dimensions that are measured in the MPI instrument. So what we've done here is we've taken 2 questions from each of these dimensions to put together a score that allows us to say something, of course, much less than with the normal MPI instrument, but something about pain severity, something about interference, something about life control, something about their supportive network, and something about affective distress, as in how emotionally are they affected. And you get a summary measure from -12 to 48. You add 8 of these questions together, and you subtract 2 of them. It's really simple, as you'll see. It takes about 3 minutes to perform this instrument, and it takes about a minute to score. So you can do this in 3 to 4 minutes in your consultation. So it's quick and easy, and you get lots of really good information. So the score, which I'm going to go back a slide. So of this summary measure, we call that summary measure the maintain score. So when I talk about the score or the maintain score, it's that summary measure, and I'll show you exactly how you calculate that. If that summary measure is 18 or above, so in this case, we've looked at 18 to 21, there is a 95.8% sensitivity. So what does that mean? So unless you're a researcher, you probably think this is Greek. Sensitivity is about an instrument's ability to capture the diagnosis. So in this case, at the score of 18, we capture about 96% of all dysfunctional individuals in our sample. So we capture them real well. But we also end up with lots of false positives, individuals that come through in our hoop where we say these are dysfunctional, but they're really AC or individuals. So specificity is only 64.3%. Which means that we're not as good at excluding those individuals that are not dysfunctional. The difference in effect, this is number of days with pain, at this threshold or higher, on average, is 24 days. So even though we're not catching everyone, we're getting a few through, and it's particularly the ID individuals that I talked about before we're getting through. But that is probably because they have a quite dysfunctional profile. So although we're having some of these false positives in, we're still having a great effect on these individuals with about almost 25 days in a year. So we catch about 17.4% of ACs that were false and about 62.9% of ID. And I'm not too worried about ID because, like I said, I think there's a proportion of ID that responds well to this if they have that dysfunctional profile. The important thing is we want to get rid of the AC. We want as few AC individuals as we can. And almost 20% gets wrongly classified here, which is not great at 18. So at an 18 or score, it can definitely be effective, but we are a lot less certain. If the score moves up to 22, sensitivity goes down because we get more strict. So we're being more strict, as in we're bringing down our circle of who we select. It becomes harder to qualify as a dysfunctional individual, which means we lose some that are actually dysfunctional, but they don't fall under our more strict criteria. So we lose them. So sensitivity goes down. And this is what happens with any test. But specificity goes up. So we're able to rule out those. So at this level, we're getting to a point where you would say this is a really good test. If you have around 80% sensitivity and specificity, that's a really good clinical test. And if it's a test that doesn't depend on life or death, I mean, this is not, we're not categorizing people for cancer here. This is a guidance. In that case, this is a really good estimate. So individuals in this group were higher, so 22 or higher, they have a difference of 34.5. So higher than the average of 30 when we just looked at the dysfunctional subgroup, remember? So effect goes up. And we're coming down to only 4.3% of ACs that are misclassified and a fewer of the IDs, but we're probably catching IDs that this is relevant for, given that the effect is so good with 34.5. With me? No questions? Yeah, good. Right, so if we look at the effect, as in how does the difference between control and intervention increase as we increase the level of this, as in, we choosing individuals. So if we were to choose individuals that have score 8 or higher, it's not effective. You see, the dotted line is the confidence interval. As it includes 0, it's not really effective. And you can see that not until 18 we really start getting a significant, clinically, statistically significant effect from maintenance care compared to control. But we can also see that it increases in a dose response like fashion. So as we increase this, the effect goes up. So we're catching a more and more relevant subgroup. So it seems the more ill the individual are, or the more distressed they are, the better effect we have. But someone might say, well, look at the end. It's going in the wrong direction. Well, that's because we don't have enough individuals to do the analysis in the end. So as we move up, all power of the analysis goes down and the uncertainty of our estimates goes down. So as we come up to individuals about 25, 26, 27, it's hard to say because there are so few individuals that scored high that we can do really secure analysis there. But the trend is very clear. Yes, you were going to say something, Stefan.
Yeah, just to clarify, the effect that you're referencing or referring to, sorry, is the effect of in terms of the gain of and in value of the maintenance care in terms of fewer days in pain. Is that correct? Yeah. Okay,
compared to control. Thank you. So we've said if you have 18 or lower, you're probably not a candidate for maintenance care. If you are between 18 and 22, it's possible that you're a candidate, but we are more uncertain. In this case, we need to listen to the patient's preferences more. If the patient are very keen on having maintenance care, then maybe we should take that into account. If they are not interested and finds it terrible, then we should definitely not push it on them. Whereas at 22 and above, we can be pretty sure that these are good candidates for maintenance care, and we can be a little bit more persistent in terms of trying to motivate them to this, because we can with great confidence say that, this is probably going to be good for you if we do this in the right fashion. Right, so as I said, takes about 2 minutes to score, so it's getting better, and a minute for clinicians to score. You could try it on yourself and see what you think. So how would we use it? Well, I think, this is new. It's not been tested, but in my clinic, this is how we've done it, and I find it to work really, really well. Either they score this in the waiting room before they come in, or I have a brief case history with the patient where just a general overview of what their condition is. I would then give them the tool and say, please fill this in. It's for me to understand more about your pain experience. While they fill it out, I make a few notes in my medical records, summarize some of the things that they've said. And when they're finished, I score it. Takes about a minute. And then I use that score straight away to go deeper into the case history by defining challenging areas. And we'll get back to that in a bit. And those challenging areas will be part of the goals that I will be setting for my patient in the treatment plan. So it obviously might be getting rid of pain, but why? What is it that pain does to you that makes you come to me? And the maintain instrument allows you to see which area of distress do they feel. Is it interference? Is it pain severity? Is it affective distress? Is it support? Is it etc., etc.? And then you can go deeper into those areas and ask clinically relevant questions that you measure these areas to be clinically relevant for the patient. So we'll look at that in a bit, and we'll also workshop that so you see how it works in reality. Right, so this is the maintain instrument. It's 3 sheets. The first sheet is really the one that you're going to give to the patients. The other 2 is for the clinician to understand. So when you print this in clinic, you really need to print the first one and the other 2 to have for you to read and reference to. But the first sheet is the only one the patient's going to need to score. And like some people have done, this can be done on an iPad. It can be done digitally. You can create it's a simple scoring algorithm with little programming. We can create a web page or something that calculates this really simply. But also doing it on paper, low tech, works really, really, really well. So we'll go through all these pages so you're with me, and then we'll workshop this in 3 cases. So first of all, we're going to look at the thing that the patient fills in. So as you can see, there are 10 questions where the patient is asked to rate from 0 to 6 different aspects. So in this first one, it's about the level of your pain at the present moment, ranges from no pain to very intense pain. And then in the end, you can, and in the very right column, you can see it says PS and a plus. And that means this needs to be added together in the scoring algorithm, and this relates to pain severity, that dimension. And we then add together all the pluses and subtract the minuses, life control. So life control, a high score in this case is good, obviously. I have extreme, so like question number 5, during the past week, how much do you feel that you've been able to deal with your problems? Well, if I've done that extremely well, obviously that's a good thing, but not at all is a bad thing. That's why they get switched around in the scoring algorithm. Also, people might think about, what about support? Isn't support a good thing? I mean, having support, shouldn't that be good? Shouldn't that be turned the other way around? Well, in this case, support reflects the severity of the condition. Someone who is really, really ill needs a support structure to be able to function. And this is one of the key elements that separates the interpersonally distressed from the dysfunctional. The interpersonally distressed have a very poor support system. They are very alone with their pain, whereas the dysfunctional patient has a support system. They have a close relative, they have a spouse, they have someone who can help them and support them in their pain journey. And in this case, it says significant other. Now in Swedish, it's translated to something else. It's a close person. And that could be a friend, it could be a relative, it could be your spouse. But in English, significant other almost always refers to a partner. So this becomes a little confusing. So you might get the question, well, what about me? I live alone. I don't have a significant other. Then you could say, well, do you have people close to you, close friends, relatives, other people that help you, or colleagues at work that help you manage your pain? So you can ask them, think about those rather than if they do and don't have a spouse. That's a question that come up in forums and discussion. I think it's a brilliant question. And a good idea would be to change the question, but then we would revert from the tested question that was done in the original MPI instrument. And I'm sure if we would change it, it wouldn't make much of a difference, but we would still have an issue saying, it's not been tested. So that's the smart idea at this point, is to keep it as it was in the original MPI instrument. Then we get a score. So you have that little memory thing with red, minus 12 to 17, red, as in no go, 18 to 21, yellow, maybe, and then the 22 to 48, green, go. And then you got your total score there. Yeah, easy peasy. Right, so you got 1 and 6 is pain severity. Those two are added together So when you talk about when you look at this, you look at those two and you say, where do they score high on this? So if they score, say, a 12, a 6, then you know pain severity is an issue. And you might think about, what is it in my arsenal as a clinician that I have that can help them deal with pain severity? Could be, modalities that help them manage pain specifically. And then we have interference. Now, interference is an entirely different thing. You can have high levels of pain and not be interfered, and you can have low levels of pain with lots of interference. So here is about probing deeper and trying to understand, what is it about your pain that makes it interfere in your life, and what are the things that you are interfered by? And then you could put those. Is it about carrying children? Is it about golf? Is it about work, etc., etc.? And then you can use those as treatment goals, just as the pain severity score. Then we have 5 and 8 for life control. We have 3 and 9 for effective distress. We have 7 and 10 for support. Right. Okay, so then we come to the next page, which is the procedure page, which is for you so that you're thinking about this in the way we think it's supposed to be thought about, because of what we found in research, not because we think it's politically right, but it's relating to what we've observed in our data. So you would ask yourself, has the patient experienced pain before? Is it recurrent? Because the patients we've tested this on are only recurrent cases. Has the patient experienced more than 30 days of pain the previous 12 months? As in, is it long enough? Is it severe enough? So we only tested those who had more than 30 days of pain. And it makes sense to select individuals with recurrent pain. 3, do they have a maintained score of 18 or higher? Are they a yellow or green candidate at the initial consultation? And now we come to the tricky one, number 4. Once you've treated them for a bit, do they respond to care? As in, at the 4th visit, can you observe a clinically relevant improvement in their condition? Is this a relevant treatment procedure for them? Now, this is not a cookbook. This is a support aid. It's about aiding your clinical judgment. You might step away from this for a number of reasons. So this is not about, pushing you into a cookbook way of thinking. It's about having a more informed decision process. So, thought now, if the answers to the following questions are yes, consider maintenance care as part of a long-term management of their spinal pain. However, initially explore the feasibility of physical activity and exercise as the main intervention for the long-term management. The reason we say that is where the bulk of evidence lies. So if the patient can manage with pain, irrespective of them being dysfunctional, and they do a great job with that, then they probably don't need maintenance care if they're such a candidate. But often dysfunctional patients do not do well because either they're passive or they don't have the tolerance to do exercise in the way they should, or cannot reach a tolerance level where they can perform exercise. So if physical activity or exercise is not effective, not feasible, or not preferred by the patient because of work, because of preferences, for whatever reasons, they hate exercising, discuss maintenance care as a secondary or primary, as in addition to exercise, or primary instead of exercise management strategy, depending on the patient's clinical status, life circumstances, and preferences. Right, and then going back to what I said before, 18 to 21, it may be cost effective and should only be recommended if there is a strong preference on behalf of the patient. If it's 22 to 48, it's likely effective and probably cost effective and can be recommended with a certainty. And you should fill your encounter with reassuring, empowering messages with the aim of improving self-management strategies, life control, reducing kinesiophobia, anxiety, and catastrophic thought patterns. So we should be, that all that explain pain stuff from Butler, all of that can be included in this encounter without it being incongruent. You can still be part of the pain science paradigm, the modern paradigm, and still be a maintenance care person, because you can fill the conversations with those concepts and ideas that are probably going to be very helpful for the patient. Right. Then move to the third part. So this is about making a decision on maintenance care. The third part is about developing a treatment plan, like I was saying. So let's say you have a patient who scores high on pain severity, questions 1 and 6. You could then go further on asking, when do they experience their pain? What does the trajectory look like? And perhaps it's more important for these particular individuals to understand the trajectory in more detail, as in triggers and events and recurrences, because we know that patients' trajectories are irregular, but over time they are stable. So individual trajectories tend to repeat themselves, but they are not stable across individuals. So different people have different trajectories, but most individuals have over time the same trajectory, which helps us when it comes to maintenance care, because understanding what happened last year might give us a great insight into what is going to happen the coming year. Interference, we can then probe into questions like ability to work, your ability to perform hobbies, activities, level of activity, household work, social activity, relationships with family, friends, co-workers, ability to plan activities, ability to experience satisfaction and joy, fear of movement, beliefs about problems getting worse with the load, activities, works, etc. So these are all questions that can dive into that interference paradigm. Life control, you can ask about how it affects their control in their daily life, how they handle everyday problems and stressful situations, how they control and manage pain with exercise, movement, behaviors, and medication. Your focus here can be more perhaps on cognitive behavioral processes or procedures. So if you work closely with a cognitive behavioral specialist, perhaps you should co-manage these patients with them, where there's a lot of life control, affective distress or support issues. Or you feel well equipped with having discussions about this, because it doesn't have to be that complex. It can be about reasoning about finding solutions, being that support system for them where they have the ability to reason about things, consider things, think about things, talk about things, and find their own solutions. In fact, that is one of the key elements of the Gladback program, is that the patient is part of the reasoning process where they themselves come up with the solutions to their problems. You can be that person, and the Maintain instrument allows you to focus on those issues fairly quickly and early in the clinical consultation. Affective distress, about mood, emotional state, how it's affected, if they get irritated, tensed, worried, or scared, emotional issues. And then the support. What is the support? What does the support structure look like? Do they have help when they need it? Do people consider their needs? Do they ask them about? Are they considered about them? Do they have an understanding of their condition? Those are also issues where you can understand. Of course, perhaps this is the area where we can do the least, but we can think of ways of perhaps helping the patient understand that they shouldn't be expected to be alone in this process. Being in chronic pain is difficult, and you need support. You need to have structure around you that can help you through that process until you get well. So that is the idea behind this, developing a treatment plan with regards to this. And like I said, this is not a cookbook. It's supposed to help you, 1, classify patients, 2, quickly dive into the challenging areas that the patient have, so that you can ask really important questions about their health state that are relevant to them, and so that you can quickly get an overview of where do I want to go with this. I don't have an entire day to talk to this patient. I maybe only have 45 minutes or 30 or whatever you do for your first new visit. You want to quickly focus on the issues at hand that are most important to the patient. Right, so I've gone over time, well over time here. So I have 3 cases and a few summary slides. So we could either end here, or we can go on with this. This will probably be another half hour going through these cases, but it'll be about looking at what we just talked about, how we can relate this to cases and scores, and so think about this. So I don't know, how do you want to go with this?
So, Andreas, what I'd like to do is, because I'm obviously recording this conference, I would like to touch on those cases, if that's okay with you. If people need to go, they can go, and then we'll reference back to this. But I'd like to have a few. There's a few questions I have dropped in, which I'd like to run past before we go into the cases themselves.
Yep.
One is from Caroline. Would you recommend giving the maintain questionnaire to patients at certain intervals to see if they change from a dysfunctional to, for example, an adaptive coper model, or the other way around, as it might be? And if so, would you suggest that there's an interval, or a particular interval that would be more useful than another? This is particularly relevant to our practice, where we're trying to collect as much of this type of data as possible.
Yeah. Yes. And yes. This is a beautiful question, and one that we've been thinking a lot about. We don't know whether we should, but it doesn't hurt. And we are going to eventually test this stability of the instrument and see if it changes, and if it's related, those changes are related to other health outcomes. But we don't have that data as of yet. But I certainly, why not? It's quick, it's easy, and if it allows you to again address like improvement. So look, you scored a 10 on pain severity when you came in. Now 6 months later, you are at a 2. Tell me what's been going on. How has this changed? And that can then focus on how do we measure those improvements and understand those improvements from a qualitative perspective. So I think, yes, that is how I would like to use it in clinic. And the time interval, I don't know. I mean, if we were to use maintenance care as most people do, a 1 to 3 month interval, I would say anything less than 3 months would be crazy, probably. And probably 3 months is too short. So maybe every 6 months or every year, depending, I guess, on the case and your procedures and how you use maintenance care and the value you want to receive from the instrument. So I don't know. I'm happy to have it. So my hope is that you're going to find this interesting and then implement that in your clinic, and then come back with feedback to me saying, this worked really great. This was really crazy. This was terrible, this was good, so that we can improve on it and make changes and make other recommendations or improve upon recommendations in different ways. So, I want to work with you guys and everyone else who are interested in this work and understand what are we doing right and what are we doing wrong.
My gut instinct on that one, Andreas, is that it could also be quite an interesting indicator as to the skill, the interpersonal skill and bedside manner of the clinician involved, and that it could actually the migration of patients one group to another, and for better or worse in certain sense, could be quite an interesting reflection of placebic, nocibic language, or the general management of that particular individual clinician in their clinical context. Because I also think that the surgery and how certain things are managed outside of the clinician's control can also impact on that patient care pathway, shall we say. There is a question from Ulrich. Have you had any thoughts as to how this tool and its use in clinical practice would translate to other clinicians in the MSK sphere, such as osteopaths and physios?
Yeah, great question. Because this is so interesting with the MPI instrument, because it's been tested for such a wide range of MSK conditions, it would be strange to say that this is chiro only focused. I would say, that the specificity and sensitivity relating to the defining the dysfunctional profile, that doesn't matter whether you're an osteo or a chiro or a physio. That relevance is still there, and where there's robust evidence to say that the prognosis for the dysfunctional individuals are worse, and the risk of a lower treatment response is higher in that group. So definitely you can that information, but whereas to osteopaths should then proceed to do ongoing manual care, probably. I don't. Yeah, I mean, I'm finding it harder and harder to say that what we are doing is incredibly unique. Evidence points us in the direction that the uniqueness about what we do is our complexity in our training and in our broad understanding and deep understanding in MSK care, and that is what gives us our edge, not perhaps the adjustment techniques per se or so. But you know,
And,
this
and
is a wormhole I'm not going to open up, because I know that.
yeah, you end up in kind of worm indeed, unpopular opinion kind of territory. But ultimately, I do think that, or at least I personally support the notion that the interpersonal, the context, Professor Dave Newell's work, who sends his regards, by the way, it becomes incredibly relevant. And ultimately, it's consumer perception of efficacy and value that will drive the not the uniqueness, but the dominance of a particular profession over another. And I think that if we were to celebrate work like yours and David's, etc., and many others in the Carl unit, for example, that is really around their efforts to demonstrate and optimize efficacy, efficiency, value for money to our consumers, and thereby present an edge rather than a technical edge as such.
I mean, because in my clinic, we have a multidisciplinary setting where we have 2 clinics and employ about 50 individuals, and about 20% of those are chiros, about 60% are physios, and about 20% is either occupational therapy or dietitians. Yeah. So this instrument allows us to have a discussion about distress, psychological distress relating to pain that transfers across occupations. It's easy to understand, it's easy to relate to, and it really helps to improve the collaboration around patients. So if we have this information and we can talk about co-management in different ways, then it allows us to talk on a much deeper level as into how we should co-manage and what we should do and what we should be thinking about, rather than just speculating about it and trying to tease out the case history. And whereas here we can actually put numbers on these different aspects. So I find it an enormous help in terms of collaboration when it comes to other professions, because it's a very accepted instrument, the MPI, and this is just a brief version of that, really, that we've been testing for spinal pain. And I don't see a problem with other people relating to that. The research we've done, it's
got one more question from Ulrich, again, teacher's pet. And who's admittedly freestyling by his own admission. Are there plans on further research to include/exclude certain aspects of maintenance treatment, such as advice or manual therapy, pain education, to see if we can, or pain medication, to see if we can focus on whether certain aspects or certain interventions are more effective than others in delivering the value of maintenance care, and then maybe even combining compassion questionnaires for the clinician, which actually is a very big topic of interest to me personally there, Ulrich. Maybe we need to talk about that at some point. So any thoughts on that, Andreas?
Yes. So the current ongoing projects in this field is the ones we've finished and the ones that we're writing up that relates to understanding how the MPI relates to StartBack and the Örebro musculoskeletal screening questionnaire, to see, are the dimensions overlapping? Could we use StartBack to identify individuals? Could we use the other Örebro musculoskeletal screening instrument instead to identify individuals? So that is coming out about clinicians' ability to quantify dysfunctional individuals using a structured case tree. That is coming out. The new projects that are in pipeline, the big one is a large clinical trial in Canada that Martha Funabashi is the head PI, and I'm expert co-author in that project, where we're testing this. We're implementing the maintain tool in a randomized control way. So one group gets to do whatever they want, and the other group gets, the clinician gets the maintain information and allows them to do a stratified approach. They all will have a recommendation regarding exercise and graded activities, and an initial treatment plan that looks the same. So that's a very interesting project, but that really relates to just testing the instrument in clinical practice to see, is it actually cost effective to put this into use? Then we're looking at if it changes clinicians' behaviors with regards to evidence-based practice at Parker University and Logan University. So we have projects going on there with students where we're seeing if different ways of implementing a tool like this can change their way of approaching patient-centered care. I have discussions about looking at this in Australia with regards to sports medicine, to see if, can we say something about maintenance care for sports individuals? Are they an entirely different category? Do they fit into the same? Are there different psychological domains that are interesting here? Are there different aspects of it? So that would be another project that I don't know might start. And then we have hundreds of ideas of testing things. I have I've started to work with Alistair at ACC. We're doing some in initial works, and he's aiming to set up a practice-based research network, and then perhaps we might be able to do something there, looking at comparing maintenance care to, say, telehealth or just visits where you talk and you do nothing. And I mean, aspects that relates a lot more closer to Dave Newell's research area to understand, is it merely psychological, or does the hands thing have an impact, and to what extent? So and then there's hundreds of other ideas, but there just isn't enough time. We have a few ideas about looking more at clinical mechanism, brain morphology, expectations and brain activity, using functional MRI to see, are there any way of understanding treatment response and these maintain groups based on those more hardcore neurological objective findings. So there's lots of ideas, but no money and too little clinicians to help recruit, and too little time. So it's just, we're any ideas are happy. If you have any ideas, any projects you would like to run, say, you want to do together with Alistair and from ACC and set up a clinical research network, and you have exciting ideas, talk to him, talk to me, and perhaps we can set something up together. I would love that.
There was a hand up from Per, but he has gone, I think. So we'll move on to the case number 1. Just so you know, Andreas, I need to pop out for a minute, so please just continue, and I'll be back shortly. And then if anybody wants to ask questions directly to Andreas, just unmute, have the conversation, and I will hopefully be back before the end. My apologies for this disruption to everyone, but I'll then pick up again with you all as soon as I'm back again. I do apologize. Andreas, please, as you are, I look forward to the case discussion.
Right. So the idea is these 3 cases will have the same structure. We have a case history, which is like a brief summary to put a face on this that would resemble something in clinic. And then we would have a maintained scoring, and then we would have clinical questions. So they will be the same for each of those cases, trying to explore 3 clearly different cases. So if we look at the first one here, we have a 42-year-old male carpenter that presents with a 4-year history of severe back pain that began by pushing a tool cart at work. He characterizes his back pain as constant and severe. He also experiences sharp stabbing pains radiating down both legs and below the knee, and he complains of burning and numbness. He also notes that occasionally his legs will give out. His initial MRI showed a L4-5 disc protrusion, which led to a decompression surgery 2 years ago. The surgery did not change his symptoms, and since then, the MRI studies have shown that only degenerative disc changes and postoperative scarring at L4-5. EMG and neurological exams are normal. Since his initial injury, the patient has not worked. He ambulates with a single point cane. Other than surgery, other treatments have included epidural, facet injections, medication trials, physical therapy, manipulation, and an outpatient pain program without relief. So from the case history here, we are already thinking this is likely or has the potential of being a dysfunctional individual. He has severe pain, long-standing, lots of interference, and probably distress relating to this. Right. Then move on to the maintain instrument. So you get a score of 38. Right, so that's a pretty high score. It's well above the level of 21 that we talked about. He scores pain severity at 10. So if we think of this, 6 might be like an average or middle score. So anything above 6 we would consider fairly high. So 10, 11, those are high scores on interference. Support a little bit better, affective distress high, and very low on life control. So this is a very dysfunctional individual. Right, and then we move on to the clinical questions. So how would you plan to use the maintain instrument with this patient? Now, normally what I would like to do is have a discussion about in breakout rooms, but we really don't have time for that. So I'll think, let's see if you can work with me, and if you have other ideas, let me know, and then we can chat about it. So how would I do this? Well, I would look at those scores and identify the worst areas, or all areas if those are bad, like in this case, and then spend a lot of time trying to understand why is it that he scores high in each of those areas, just like we talked about. We would then proceed to question number 2, to set the treatment goals accordingly. Which of those things are changeable? What are those can actually be modified so that we can expect to be and expect to be better? And then focus on those things and set those as treatment goals. Also considering that those should be important for the progression of pain. So if it's about doing something that is irrelevant or might even be detrimental, those might not be a good goal. So, and then we come to the third. If the patient does respond to the initial treatment plan, what is the recommendation and how would we provide for the patient follow-up care? So this would be a classical case where maintenance care would be a good idea. We would consider exercise. Does it work? Is he pain-free entirely? Does it fix it? Or is it just partially better or not better at all? Then maintenance care here is very, very, very good alternative. And then if the patient does not respond well to the initial treatment plan, what would the recommendation be then? Well, it would obviously be not maintenance care because manual care doesn't seem to work well. In that case, we would probably co-manage this or refer it off to a physiotherapist or a pain specialist. Perhaps a physio with a specialization in pain that could help them move forward. Or if you have other strategies yourself, as in working with exercise and rehab, or even cognitive behavioral therapy, that might be a way to move forward. So that was case 1. Any comments, questions, ideas? I mean, can you see how this works together as in making this a valuable instrument to help in the process? Any questions, ideas? So I can only see the people that speak now. So I don't see anything in the chat in this round. So if you want to say something, unmute, say it, turn the video on. No?
There's lots of thanks from various thanking you for speaking, but no further questions as it stands at the moment.
Great. Right. So moving to case 2 then. I'll just swiftly go through these. So in this case, we have a 46-year-old female software developer that presents with a 5-year history of mild low back pain. She experiences multiple flare-ups each year and has been out of work for the last month with a typical exacerbation. She describes her pain as constant, dull, with an occasional sharp stabbing pain in the upper axial lumbar region. Her symptoms are improving overall. Neurological exam is normal and imaging studies are unremarkable. So this could very well be in a dysfunctional or somewhere in the middle. So when we look at her score, it's actually quite low. She scores 10, which means she does not cross the line of at least 18. We can see that pain severity is pretty low. We can see that interference is pretty high. She scores an 8 on interference, and support as in pretty low, 4. Affective distress 4, and life control high, which is good. So in this case, we can single out interference as one category that is stressful for her, and that is a problem. Yet she scores low overall on distress and seems to be a pretty active and functional candidate. So how would we use the dimensions here? So I would probe into the interference area and set goals around that, probably with a exercise-based or activity-related treatment plan, either by myself or with a physio. I would ask the patient to come back if she have other issues, like we did with our control intervention, and see if we could manage their pain like that. If she responds well to the initial treatment plan, having her come back as pain comes back would be a good idea. If she does not respond to the treatment plan, then obviously we would have her seek other options of care if that works better. Right, so case 2, you can see, so here we have an AC or a good one, not fitting for maintenance score, yet the maintain instrument is helping us here to perhaps identify interference areas that we can discuss in more detail. So case 3, right. A 35-year-old male postal worker supervisor that complains of left-sided low back pain radiating into the left calf. He reports onset after involvement in a motor vehicle accident 9 months ago, where he was T-boned at an intersection. He characterizes his back and leg pain symptoms as moderate to severe and that they have not improved over the last 6 months. The patient has neurological deficits on exam, and a recent lumbar MRI is unremarkable, other than a central disc bulge at L5-S1. Oops, sorry. So initially, the patient returned to work about 3 months post-accident, but stopped working within 3 weeks after complaining of back and leg pain symptom aggravation with standing and working and walking at work. Right, so we move to the maintain instrument. He scores 20. So he is somewhere in between 18 and 21. So in that area where preferences are really interesting and important, and their ability to perform activities, obviously. So if he can manage on his own and he doesn't have a strong preference on maintenance care, then that would not make him a candidate. If he does not, if he's quite passive and he falls into that category of say interpersonally distressed individuals that are dysfunctional but pretty passive, then maintenance care, with the dominance towards that, then maintenance care might be a good idea. So he scores low on severity, he scores low on interference, he scores high on support. So he has a lot of support, which is making him a dysfunctional individual. He scores high on affective distress, but quite low on life control. So here we would look at what are the things in terms of support that needs to be understood. What is it he needs help with, and are there issues there that are modifiable that we can intervene with? We could look at the life control aspect. How does he manage life? And we could also look at the affective distress, which is rather high, at least somewhere in the middle, to see what are the emotional consequences of his pain. Same thing, so we talked about this, so intervening in those areas, setting treatment goals, relating it back to how he responds to the treatment plan and his preferences. If he responds well, he has the preference of maintenance care, he is passive, exercise doesn't work for him, then he's a good candidate. If he doesn't respond well or has a good active strategy that serves him well, then that will be the point of call. Right, so that's a way of thinking. Any more questions on that? Great, so I have a few more. What, sorry?
No, just saying, going strong, no further questions for the time being.
Actually, Andreas, I've got one on this, actually probably referring to the previous one as well, if that's okay.
Yeah.
I think it was Chris Chippendale who sort of suggested that it can almost be boiled down to as simply as patient maintenance care is relevant for the people who like it and not for the people who don't. How do you feel about the girl in case 2 who obviously was fairly low? Would it still be relevant to have that conversation of going, we can offer something like this where you come in and we look after you from time to time? How does that sound to you? Or would it generally be believed that actually we shouldn't be doing this with these people?
Yeah, so with her, she's probably an AC individual. So with her, even though she might like it, it is likely from the data that we have that she might probably experience more pain and actually have more visits if we were to put her on a maintenance care schedule. So she would be in that category that we think is detrimental for. So there would be a strong recommendation on saying, I think you could manage this on your own. Even though you think this is great, I think you can do better on your own. And if you need me, just call me and then we can manage you. So that's where I think, you can make those strong recommendations in those below 18 and above 21, where you can say, I have a strong case for this strategy. I have a strong case for that strategy. Whereas in the middle is where we more go with, what are your thoughts and what are your abilities and what is your situation that allows you to either exercise or do active strategies or have a more maintenance care oriented schedule.
Great. Thanks, Andreas.
Summarizing this up, a few more slides, then I'll let you go and have a wonderful weekend. So what are the clinical implications here? Right. So we have a clear patient profile. More than 30 days previous month, good effect at the fourth visit. Dysfunctional patients with high severity, high interference, high affective distress, low perception, low control, low activity levels, a score of maintain or over, in other words. And if we take that into account, we can expect fewer days with activity limiting pain, about 30, more pain-free week on average 10, less acute flare-ups, cost neutral from a patient perspective or a healthcare perspective is normally what we would say, and probably cost saving from a societal perspective, because we know that pain is associated with a cost. And this is also a publication that is coming out soon that really strengthens this whole health economic perspective on where we include the maintain instrument categories in. So that will be a very important publication when that comes out as well. So how does it work? Going back to what we said, we don't know. Could be a neurobiomechanical mechanism which relates to segmental range of motion, neuromuscular function, pain inhibition, etc. It could also very well be a psychological mechanism. Much points in that direction. That is about safe framework, reassurance, coping strategies, reducing fear avoidance, behavior, and anxiety. So when and how? Just reiterating. Exercise self-management first. If active strategies are not effective or not feasible, consider maintenance care. Reduction of fear, empowerment, improving coping strategies, increased activity. And like we also talked about in the question before, transition from DIS to AC is perhaps the core objective of maintenance care. And using the tool to evaluate this might be the way to go. We don't know, but we're at the forefront here. We're learning new things. So, and going back to the qualitative piece that we published, provide high value care. Provide care that improves the quality of patients' lives, care that is structured, accessible, appreciated, and that is patient-centered. Please go and look at that paper to understand what they think about it, because that is how I think we should practice, in particular when it comes to maintenance care. So a few acknowledgments. Like I started off with, clinicians and patients are the absolute heroes of this. If there weren't those 40 of those that we started off with who collected data on those patients for an entire 12-month period, they spent 2-3 years entirely, because from the first initial included to the last that stopped, it was a 3-year project, really. They are heroes, and they were an absolute necessity for the success of this project. There's been so many co-authors on these projects. I can't mention them all, but 2 that have been instrumental have been my PhD supervisor and now close colleague, Associate Professor Ibn Axian, and Professor Charlotte Leboeuf-Wiede, who was the brains behind this whole project from the beginning and has been in the background helping all the way through. Also, the funding agencies who made this possible funded this research. ICON, a Swedish funding agency, ECRA, our European funding agency, and also KI, my university, who supported me in internal funds in different ways. So that was it. I am now finished with my presentations. If you have any questions, feel free to email me or call me. I'm happy to do whatever I can to answer those questions. And just like I said, I would love it to have the input from you as expert clinicians who are putting this to use, as in all the good things and all the bad things, so that we can continue on improving this to provide better healthcare. So now, how do I stop sharing? I think I pushed this one.
Yeah, there you go. You've got it. So, Andreas, first and foremost, I'd like to extend my personal thanks, but also the thanks of the people that have been posting within the chat, thanking you directly for not only your work as a researcher, but for your commitment, balancing that work against clinical work and really trying to bring it into real, which I appreciate is both a thankless task and an incredibly difficult one from a logistical and from a thought processing point of view. I appreciate deeply your thanks to our colleagues and clinicians that are in the field collecting data to be analyzed. However, I do also feel personally, again, very strongly that our profession as a group needs to very much embrace the researching arm of our profession and recognize it as an incredibly important driving force to increasing both the trust and the value of what we do as professionals, and really to pay its respect for what it brings both to our patients and our personal lives. So thank you very much for producing not only relevant but also inspiring research together with your colleagues. So please share that plaudit across. I'd also like to just open up the discussion further. So perhaps there are people here who want to discuss further. I can put that on you, Andreas. So if you want to go, by all means do. I appreciate your time that you've already shared and spent with us. But I'd be very much open to a further continued discussion on the subject, because the psychosocial component of what you are laying bare, of what your colleague researchers are laying bare, what David Newell is discussing, and that so many other people are trying to break through to our profession, I think is going to be an important part of its future. So again, personally, thank you. And I look forward to further discussion and implementation of your tool in our professional environment.
Awesome. Thank you. Thank you. Yeah, I'm happy to stay on if there are any questions or discussions, or I love this. So I have no other.
I'm picking up flowers for my wife. That's the only reason why I had to boost, because it's her birthday. And that's why I had to leave the camera. Sorry.
Sorry.
Is there anyone of our guests or participants that would like to field the question directly to Andreas or anyone else in that field? But I suspect Andreas will have the answer. If so, speak up. In that case, I'm going to ask a question of my own, Andreas. I know this is going to be conjecture, so I'm not expecting an evidence-based response from you here, but do you feel that we are right in the sentiment of driving excellence or through to excellence in terms of our patient communication and its importance to the future of our profession?
Oh yeah, I mean, I think that is unequivocal. There is a wealth of information out there today that suggests how we speak to our patients, the words we use are important. There was absolutely brilliant presentation at the ECU convention in Utrecht, where this very topic was raised, where they looked at the nocebo of damaging language or using certain phrases. So I think it was in the Lancet papers, it's in the systematic reviews. The way we talk and communicate to our patients is paramount. We can't get away from that. That is very, 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 very important for any healthcare provider. So I no, certainly, yeah, I don't think it's conjecture. I think I think we have good data support that is very, very, very important. What I'd like just like a finishing remark, if there are no more questions. I think when I came out into practice in 2002, I was pumped full of the biopsychosocial model. As in Stephen and I, we were in the same year. We all knew it was good, it was important. We knew about the Bournemouth questionnaire, etc., etc. But getting into practice and operationalizing the biopsychosocial model, as in how do I identify relevant risk factors in clinic in the meeting with my patient? Using the Bournemouth questionnaire, and the other ones that were out there weren't really accessible, because one, for me, it wasn't in Swedish. Two, it was really long. I couldn't really see it fitting into a normal procedure. And then Startback came, and then we found out it wasn't really that relevant for Kairos. There wasn't robust evidence suggesting that it does affect outcomes. Where there's some suggestion that it might say something about the prognosis for our patient, but it wasn't like mind-blowing like you would expect from the other research that they did in primary care. So for me, the Maintain tool is about I can't even say it is about making the biopsychosocial model real in care. That we introduce this, we measure things, we can say if it's a relevant or not relevant risk factor, and we can act on it. I think that is key to this work, that we're actually bridging the gap here in creating something that is easy enough to use and relevant enough to use to allow us to include that in our day-to-day work, other than just being a theoretical model on top of clinical practice that we talk about and think about and relate about and have, well, it didn't work out because we think X, Y, Z, or it did so and so because I think, theory, this, that. So I think that's the thing. We need more things like this to put the biopsychosocial model into practice and a part of practice, into instrumentalizing it, making it into something that is tangible, usable, understandable, that we can measure. So that is my drive about this, and I'm hoping that's where we're moving with this. So that was my just final point.
Wonderful. Andreas, again, personally, so I've actually managed to get the flowers, so that's all good. I'm back in the good books. Andreas, I would like to thank you tremendously, and your team, and your kindness for your time, your work, your dedication to it. I would like to say that my team and I are looking at implementing this tool into our practice, and I would like to lend you my team's support in identifying further factors. One of those is, for example, that we are going to start implementing it and reviewing initially after 3 months. We will question the MPI tool and then look at whether the profiles change. And then after the first re-evaluation at 3 months, we probably will look at first at doing it once every 6 months. And then hopefully once we've collected a year's worth of data, we'll then feed that back to you to see whether there's anything of any value there. In closing, I would also like to say that the fact that you're traveling across a very murky field, both politically and financially speaking, because I think what we're really discussing here is that there is a perceived vested interest in maintenance care, financially speaking. There is this ideal that if 100 new patients come in and are appropriate for care, that 100 of them translate into maintenance care so as to fill the fiscal diary and the financial goals of the individual clinician. And I personally feel that that is where some of the discomfort around this discussion and this narrative comes from. Yeah. The fact that you are willing to lay it bare is both brave, but and sometimes probably thankless. but I'd like to say that I support that effort fully, because I can see its value in what it does in legitimizing and supporting our profession, and that fear of that ilk is entirely unnecessary, because I think it will actually increase trust in the usage of our services. It will increase the public perception and authority that everybody keeps talking about for our profession. And as such, I can only thank you for the work that's been done. And I'm sure that everyone around this presentation feels the same, or at least similar, unless they have very different views around the value of maintenance, etc. In which case, I would also really value their input, because ultimately, the unpopular opinion is really what we need to be looking at, I believe. So again, thank you so much. Is there anyone else who would like to say anything? Just open up your mic. This is the moment. And otherwise, 5, 4, 3, 2, and 1. Have a wonderful weekend, everyone. Andreas, I can't thank you enough. And have an amazing rest of the weekend, everybody. Yeah, stay wonderful.
Thank you. Thank you so much. Bye-bye.
Take care. Bye-bye.